Hi, Lawrence LeBrocq, Managing Partner of Garces, Grabler, and LeBrocq, and I'm here with Dr. Abdul Arain, and you're at Victim to Victory, the authority in personal injury. Today we're going to talk about surgery, more specifically spinal surgery. We're going to talk to Dr. Arain about the articles he's written. We're going to talk about billing, how we treat people as a client and as a patient when they're injured in either a collision, an automobile collision, slip and fall, trip and fall, or a construction accident. Dr. Arain, welcome to the show.
Thank you for having me.
My pleasure. Why don't you tell us a little bit about yourself, what your specialty is, your background in education, and how you've come to be who you are and where you are today?
Yeah, so I'm an orthopedic spine surgeon. I grew up in California. I did my undergrad over there. Studied biotech, minored in anthropology, and double majored in chemistry. Went over and taught for a year. I was a high school and middle school teacher. I taught science to 7th graders, 8th graders, 10th and 12th graders. Then I went over to Tufts for my master's, and then I went to SUNY Upstate for med school and Albany for orthopedic residency. Then I went to NYU for a fellowship, and then I found myself practicing in Jersey as an orthopedic surgeon.
And how long have you been an orthopedic surgeon?
This is my 5th year.
Okay. Yeah. And what do you specialize in? Because every orthopedic surgeon either normally specializes in extremities or the spine.
Yeah, so I'm an orthopedic spine surgeon. So I do primarily spine surgery, but I also take a lot of call. I'm usually on call about half the month. I still enjoy it. During that time, I do a lot of ortho extremities as well, fracture management, things like that. But I primarily focus on spine.
Okay. So do you do any other surgeries other than the spine?
Yeah, I mean, I do fracture fixations, hip fractures, wrist fractures, shoulder fractures. Every now and then I do some simpler scope surgeries, but basically just the bread and butter orthopedic surgeries. Nothing too complex when it comes to extremities.
Right. But the spine is what you would consider your specialty now.
Yeah, that's what I went to fellowship for, and that's what I tend to do.
So, Dr. Arain, here's a little bit of a unicorn, because in the industry, most orthopedic surgeons either specialize in the spine or extremities, normally knees, shoulders, maybe elbows, and then you have, of course, your ankle specialist, your podiatrist, your foot specialist. So it's very unusual, but I commend you on the ability to do so many different types of surgeries. You're with a company now called One Oak?
Yeah, One Oak Medical.
All right, and where are you located?
So I'm located in several locations. I have offices in Paramus, Jersey City, Woodbridge, Island, Hoboken, Randolph, and I think and Wayne. So I work 7 days a week, as a lot of people know. My busiest clinic days are Saturday and Sunday. I love working. I start losing my mind if I'm not at work, so I'm all over the place.
Just so everybody knows, in the industry, Dr. Arain is known as a workaholic. He works extremely hard. He's a very busy orthopedic spine surgeon. Doctor, let's talk a little bit about the process. If somebody comes to you with some complaints, take us through what your role is, how you treat a patient, and what the normal course of the relationship is.
Yeah, so first and foremost, I'm a doctor, so that's my due diligence to the patients. You have to treat everyone like you would your own family member. So we assess them, take a thorough physical, do a thorough physical exam, take a thorough history, figure out what's really bothering them. Right? Some people may come in and saying that they've got arm pain or leg pain. Usually there's no such thing. It's usually a joint. It's either the shoulder or the elbow or the neck. So you have to really delineate exactly where the pain is coming from, what the symptomatology is. And then, then we'd get advanced imaging. Initially, you start off with x-rays, get them started with conservative care, and monitor the response. If they're getting better, we continue in that course. If they're not getting better, then we get advanced imaging, MRI, CT scan on rare occasions, only when there's concerns of fractures that you can't appropriately visualize, or if they've had previous hardware and you need to get a CT scan for whatever reason. But usually follow up with an MRI, and then you go through your care path and treat them appropriately. If they're not getting better, the next step is usually, some sort of a slightly more invasive treatment modality. You can train, you can add modalities such as acupuncture, hot and cold therapy, more stim therapy, multimodal pain medications. But when all those fail, then eventually I would, you would try an injection, if it's a joint injection or an epidural. And then, when everything else fails, at the last resort, then you have a discussion about surgery. And I usually never book people off the first discussion. I always tell them, hey, I'm talking to you about surgery for the first time. Even if you wanted surgery, I'll have you come back in 3 to 4 weeks, maybe with a family member, or maybe after you had time to think about it, and then we discuss surgery further.
Right. So when you're saying conservative care, you're talking about your chiropractic treatment, your physical therapy, and having some of those modalities, the heat, the electric stim, the ultrasound, maybe some adjustments, a massage, to try to reduce the pain in those areas.
Yes.
And then when that fails, you talked about injections, whether it be an injection into a joint such as a knee injection or a shoulder injection, elbow, but there's also the injections into the spine, or the epidurals.
Yep.
What is the purpose of an injection into a joint?
Okay, so pain is multimodal. There's many reasons of why pain exists. Oftentimes, especially with personal injury victims, car accidents, workman comp accidents, you have a lot of anxiety and PTSD and other sources of pain. That's one source of pain. The other source of pain that's most common is the actual acute injury, tearing of muscle, herniated disc, tearing of tendons, ligament injuries, or just increased inflammation. Your overall body inflammation increases. So sometimes someone may not have injured their shoulder, but because their neck is bothering them, now their shoulder is bothering them. So the purpose of the injection is primarily to reduce that pain, to let the patient go down to baseline, and then you can reassess them and see exactly what's bothering them more, or to see if that just sort of solves the problem. Sometimes it's just an acute inflammatory reaction. For example, if someone comes in with severe shoulder pain, can't lift their arm, you give them a cortisone injection, which is relatively safe, relatively pain-free, and you never have to see them again. That one injection knocks out the inflammation, their body goes back down to baseline, they return to sports, everything's just fine. So the injections can be a source to control the problem, even to a certain extent permanently control the problem, or it can be as a diagnostic tool.
Right. And then when that fails, that's when the surgical recommendation comes into play.
Yeah, that's when we discuss the surgical options, go over the risks and benefits, go over the recovery, and then we have, at least I see the patient a few times after that, and then we finalize a decision if or not we're going to proceed with surgery.
And you mentioned the word acute before, which is a new injury, something that's, if it's acute, it's new, as opposed to a degenerative condition. Now, as you know, we deal in the legal industry all the time. We have defense doctors that say everything is degenerative in nature. Mm-hmm. How do you determine if something is an acute injury as opposed to a degenerative condition of the body?
So that's a good question, and it's kind of complicated. Sometimes you can use imaging findings to confirm that. If someone obviously has a fracture, that's an acute injury. That's not a degenerative problem. Sometimes the MRIs will show edema and inflammation, which is more of an acute reaction, not something that's been there for a while. For the spine specifically, herniated disc will sometimes have a fluid signal that can suggest that that'll be different from the remainder of the disc. That suggests that this is something new and not part of the normal degenerative process. Also, if the fluid signal in the disc is slightly darkened but not completely black and not completely degenerated, then that indicates that whatever injury happened had to be relatively recent, within weeks to months rather than years. So you take that into consideration. In addition to that, you take the patient's clinical history. All of a sudden, you have this very healthy young person that never had any surgeries, never had injections, now is all of a sudden decrepit and requiring therapy just to get by, requiring pain medications, and then now needs surgery and needs injections. So then you know that must have been something that happened. And unless the history provides some other source of trauma or some other source of why he had an acute exacerbation of some pre-existing pathology, then you would attribute the current injury to his or her current complaints.
Now, you just said an acute exacerbation. So if somebody does have a degenerative condition of the spine, they may have some of the normal aging process. They may have some arthritis of the spine. Can you have an acute trauma exacerbate or worsen a pre-existing condition?
Yeah, 100%. I mean, no matter what happens, everyone has degenerative changes in the spine. From the day you're born, you start accumulating arthritis. I think the key difference is the clinical picture where you have a patient that didn't have any problems, and all of a sudden now they have problems, which means there must have been something that happened to that patient that's causing them to present in that way. Even within a degenerative process, you can have stable disc bulges and not herniations, and you can have a stable spondy, some instability, but the injury can convert that into an unstable injury and something that's more progressive and now symptomatic. Right. At the end of the day, the body has compensatory mechanisms where even if you have a small amount of degenerative changes, some pathology in the spine or other body parts, your body will compensate. That acute trauma may just push your body over into that area where now you're symptomatic.
So now let's talk a little bit about some of the surgeries you perform, because there's different types of surgeries. There's laminectomies, there's discectomies, there's fusions. What type of spinal surgeries, let's stick to the spine for just now, do you perform?
So I perform the vast amount of spinal surgery. So I perform laminectomies, lumbar spine fusions, anterior cervical discectomies and fusions. So anything that's in the realm of spine surgery, I perform. I don't do injections. I leave that up to my pain management colleagues. They do, significantly more injections than I do. I have been trained during fellowship to do injections, but at the end of the day, if there's someone that just does that, they're going to do it better than me. So why bother? I'll stick to what I do best. I'm relatively conservative. I do a lot of more laminectomies and decompressions than I do fusions. Fusions do have long-term complications, and people don't realize that. But if you're young and you get a fusion, almost guaranteed that the level above or below that fused level is going to take an accelerated degree of damage, and now you're going to have to address that at some point.
And you and I understand the reasons why, but could you explain to the jury what happens when you fuse a disc, why the degeneration occurs at either the disc above or below, or sometimes both?
Yeah. So once you fuse a level, that basically means that there's no more motion in that level. That's what takes care of the pain and the problem. The problem is once you fuse that level, your body's going to want to move. Every time it moves, all the motion now has to occur at the level above and below. So you're naturally going to wear and tear those levels faster at an accelerated rate. So, 5-10 years from that fusion, if you get repeat MRIs, now you can have degenerative changes and accelerated degenerative changes, which I personally would like to call post-traumatic changes because they're after initial trauma, post-traumatic adjacent level changes. You're going to have that at an accelerated rate. And now, at some point in your life, you may have to address that. So, that's why I think that the overall effect of a disc herniation or a fusion is actually very severe, and people don't realize that because they only take account into what you had to do initially. But down the line, 5-10 years from now, your life is completely changed.
Yeah, there's been plenty of articles written on that too, about the adjacent disc syndrome after a fusion and all the complications and problems that occur. So let's talk about the different type of surgeries. Basically, you talked a little bit about a fusion, but what is a discectomy? What is a laminectomy?
So let's take the lumbar spine, for example. One of the most common injuries.
Now, the lumbar spine is the lower spine.
The lower back, the lumbar spine. So one of the most common injuries that people have are disc herniations. Happens in all age groups. These can be very large, can be on various parts of the spine. It can be central. It can be off to the side. It can be way far lateral. So the goal in the spine at the end of the day is to decompress. Nerves need space to breathe. When you have a disc herniation or you have any degenerative change or any type of pathology in the spine, the symptoms basically arise from the compression of the nerves. So your goal is to decompress that spine, whatever you have to do. Whether you have to take down bone, take down soft tissue, whatever you have to do, you have to basically decompress the spine. So, one of the most common procedures that I do is called a laminectomy. Also, very similar to what we call a microdiscectomy. The way I do it is I do it through tubes. Some people do an open incision where they make a big incision and then take all the muscle down. But a lot of the younger guys, such as myself, what we do is we make a small incision, about a dime-sized incision. We use tubes to go down into the spine, and we take a little bit of the bone down and basically free up the nerves. The procedure itself takes about 25 or 30 minutes. The recovery is very rapid. Patients go home the same day. Most of my patients do not finish their 2-week post-op medication course. They're able to drive about 2 weeks later. I encourage them to start going to the pool and working out at 2 weeks, start physical therapy in 2 weeks, and then get back to the gym in 4 weeks. So the recovery is pretty rapid, and I expect them to go back to professional sports, including rugby, basketball, all that stuff, in about 3 months. So, the recovery is very rapid.
Right.
Now, on the other hand, on the other spectrum, on the other end of the spectrum, you have lumbar spine fusions, which are, not as simple. That's when we actually, there's many different ways to do it. Basically, the goal of a lumbar spine fusion is you're going to take down a significant portion of the joint, therefore causing instability, and therefore you have to fuse the spine with hardware, whether that's a cage or screws in the back or rods, or some people just do bone graft. That's a fusion. So that recovery is significantly longer. For those patients, I usually have them stay overnight in the hospital. I know a lot of people are doing these as outpatients. I don't feel comfortable like that. I think, I'm worried about my patient's pain and other factors, so I keep everyone in-house in the hospital for at least one night. When you go home, you're still encouraged to mobilize. You're still encouraged to move around, but the recovery is definitely a lot slower. Going back to driving, you're talking about 3 to 4 weeks. If you have a desk job, you can go back to work in 3 to 4 weeks. But if you have any heavy lifting involving, like construction work or something like that, give yourself a good 2.5 months. And then sports, probably in about 6 months.
Right. Now, how many surgeries would you say do you perform in a year? Let's start with your simple discectomy or laminectomy.
That's a good question. So I can tell you how many I perform in a week.
Right.
And we can kind of tabulate it from there. So usually simple discectomies anywhere from 4 to 6 a week. ACDFs anywhere from 1 to 2 a week. And fusions probably 1 to 2 a week. It all depends. For example, next week I have 3 A-lifts, 3 lumbar spine fusions, and 2 ACDFs, and about, I think, 9 laminectomies. So, that's something along the lines. So quite a bit of surgeries.
That's a lot of surgery.
Yeah.
And how long have you been keeping this type of schedule?
Since I started. I have not taken a single day off. I don't take holidays off. The only time I'm off is when we're more snowed in or when we don't have staff to work the clinic.
Okay.
Yeah.
Do you have anything to do with the billing at the firm?
I submit my bills, and then I submit my bills. Our billing team takes over after that. Obviously, when sometimes it comes to LOPs, I'm sometimes involved in the negotiating and whatnot. But usually, the billing team takes care of the majority of it.
Right. And Doctor, looking over your CV or resume, I saw that you've written several articles. I think you mentioned approximately 70. And do any of them pertain to the personal injury world?
So I think, personal injury, just like any other form of medicine, it encompasses everything, right? Because not only is it just acute personal injury, it's also general pathology that patients have. I think as a orthopedic spine surgeon, one of the, I've written 70 articles, but there's one specific article in which I talk about cervical radiculopathy and how to differentiate myelopathy, radiculopathy, and other manifestations.
Can we just start off by defining what radiculopathy, what
Yeah, so there's cervical radiculopathy is basically when you have compression of the nerve causing, pain going down the arms. People have this severe numbness, tingling, really, really bad, annoying pain. Myelopathy is when you have actual cord compression, and that's a bit of a grave diagnosis because that basically means when someone has those symptoms, such as, they'll start dropping things with their hands, their handwriting will change, they'll have some weakness in their hands, they'll have balance issues. That's a grave diagnosis because that already means that you have some permanent damage. So at that point, there is no conservative care. So anytime someone has those symptoms, it's very worrisome. but that can also be confused with other pathologies, such as vitamin B12 deficiency, myeloma, vast, GBS, Guillain-Barré syndrome, like tons of different pathologies that can kind of mimic that. So it's very critical to be able to differentiate, acute injuries that are surgically treated, such as myelopathy or radiculopathy, versus other mimickers of those pathologies, and also other pathology of the upper extremities. Like, for example, is it truly coming from the neck, or is it coming from the wrist or some other nerve compression? So in that article, I kind of go through the various upper extremity pathologies and try to help create a guideline on how you differentiate, cervical myelopathy from radiculopathy, from carpal tunnel syndrome and cubital tunnel syndrome, and some other neurologic manifestations.
I don't want you to go through the entire article, but just give us a little bit of a breakdown on how you can tell the difference, what testing you can do, or.
Yeah. So I think first and foremost, you gotta get the history of the HPI, the history of the patient, right? Age, mechanism of injury, the full symptoms, right? Are they having problems what are they complaining about? Is it just weakness, or is it weakness with balance problems? Your exam findings will give you objective proof of those symptoms. So based on that, you can kind of have an understanding of what's going on. After that, the imaging will tell you a lot, right? If there's cord compression, then you're thinking more myelopathy if it's really bad. If it's just like a disc herniation that's way over to the side on one side, and that's where the pain is going down, then you're thinking more radiculopathy. You can do an EMG, which is a nerve test where they can actually pick up if the compression is coming from the neck, or if it's coming from somewhere in the elbow or the wrist, or if it's both, right, which is called a double crush phenomena, which carries its own prognosis and difficulties in treatment. And then once you've kind of differentiate all that, then you can kind of establish a care path for the patient. But it's very important to figure that out, because if you don't know what the diagnosis is, the patient is gonna be just running loops and not getting better. They'll get injections, they'll get all this other therapy, but unless you know what's going on, the patient won't get better. As a provider, you're going to be writing the physical therapy script. You're going to be writing the chiropractic script. So you have to give a diagnosis. The diagnosis has to be as accurate as possible, because certain things that help radiculopathy are very dangerous in someone that's myelopathic. If someone has cervical myelopathy and you manipulate their spine through chiropractic manipulations, you can potentially paralyze a patient, right? So that's very critical. So I think that article was pretty relevant for personal injury patients.
You mentioned double crush syndrome. Now, what is double crush syndrome?
So double crush syndrome is when you have compression in two different areas of the body, right? So somebody could present with severe numbness and tingling in, let's say, the thumb, the index, and the long finger, and they have pain going down the arm, and they have a little bit of neck pain. So now you're thinking, okay, is this carpal tunnel syndrome? Is it coming from the elbow? Is it coming from the neck? And the reality is it could be coming from multiple areas. So then if you get your MRI, it shows you, corroborating evidence that, there is compression in the neck. You get your EMG, and it shows that there is an active radiculopathy in the cervical spine and active carpal tunnel syndrome.
Right.
So then they have two different pathologies. They have a separate problem with their wrist that's causing the numbness and tingling in the hand, and then they have a separate problem that's causing the weakness and the numbness and tingling going down the arm. Then you got to figure out which one's really bothering them more, and then you treat that problem. You never treat everything at once. There's no reason to do multiple surgeries, because they may not need both.
Right.
So treat the problem that's bothering them the most. The way I would do it is I would generally start off with a carpal tunnel injection, see how much relief they get. If they say, hey, this is very livable after this injection, then I would focus my attention on that, as that's much less invasive than focusing my attention on their cervical spine.
Now, I just want to talk to you a little bit about radiculopathy. Now, if somebody has a cervical or a radiculopathy coming from a herniated disc in the neck, where are they going to most likely feel that pain?
So it depends on which level it is, right? If it's higher up in the cervical spine, they'll actually, one of the most common complaints is actually headaches, cervical headaches. They just say they have these really bad headaches. If it's coming from lower down, it'll be going more into the hands, right? So it all depends on where the based on what level the herniation is, it'll have a different manifestation of symptoms.
And then what happens if it's in the lumbar or the low back? Where do they get the radiculopathy?
Once again, depending on which each nerve root has a specific dermatomal distribution. It's not 100% accurate, but more or less, most people have pain in that particular dermatomal distribution. So most disc herniations in the lumbar spine and most pathology in the lumbar spine occurs at the L4-5 and L5-S1 level, which are fairly lower in the lumbar spine. This will cause pain in the buttock region going down the posterior and the posterolateral, like the outside of the leg, into the foot. That's classic of pathology in the lower lumbar spine. But then again, they could have pathology higher up that can also cause pain in the groin. If a disc herniation is very large, I have had personal injury patients that actually present with symptoms of what we call cauda equina syndrome, which is something that you got to get to the operating room sooner than later. So it all depends on how bad the compression is and what level it is.
And cauda equina syndrome is pressure to the point where they could be incontinent or, if it's a man, impotent and have problems from that. And that's an emergent
that's an emergent. That's if someone presents that way, I'm telling them to go to the hospital, and I'm taking care of them within 24 hours is what the literature recommends.
Now, which I always find to be a little extraordinary is the herniations in the mid-back or the thoracic spine, because what can that cause problems with if you have impingement or herniations in the mid-back?
So, one good thing about herniations in the mid-back is that they are stabilized by anatomy. Your thoracic spine is connected to your rib cage, so that provides an internal brace. Right. So even if you have a herniation, it's not necessarily progressive. So a lot of people do have herniations, but for the most part, those herniations are either asymptomatic, where they're not feeling them, or they get better and they don't progress. The problem with the cervical spine, the neck, and the lower back, the lumbar spine, is that those are mobile areas. That's where all the motion occurs. So pathology in the neck or the lower back is progressive. Now, when things in the thoracic back do get pretty bad, when the disc herniations do get severe enough to cause cord compression, you can have similar symptoms as you would with cervical myelopathy. You can have weakness in the legs. You can have severe lanceating pain across the chest, and sometimes at certain levels it can be confused by pain from kidney stones and gallbladder pathologies as well. Right. So it is rare, but that is something that people need to pay attention to. If someone doesn't have any neck pain at all and the MRI is clean, but they're myelopathic and they're having difficulty ambulating, they're losing balance, definitely get an MRI of the lumbar of the thoracic spine, because they could have cord compression at that level.
Now, I'm sure you've done some emergent surgeries. Is there any particular cases that you can recall that somebody was had a serious acute injury and had to be operated on right on the spot, an emergent situation where you had a great outcome?
Yeah, I would actually say that for the most part, the emergency surgeries have the best outcome, because they're in the acute setting of the injury and they have severe symptoms, and they always get better because they don't know mediocre. They only know bad and good, right? So sometimes those are the best outcomes. There was, in particular, an emergency department doctor who had a disc herniation, and she said she could not walk, she could not, do anything. She's in severe amounts of pain. We got an urgent MRI for her. She was a massive disc herniation that was just extruded and inferiorly migrated. So I took her to the emergency room within 24 hours. We decompressed her spine, teeny tiny incision. It took me a while. It took me about an hour and a half because it was extremely compressed, and I had to wand the tube down to really decompress distally, which is a little difficult, especially when you're doing it through the tubes.
Sure.
But I wanted her to not have a large incision. I wanted her to have a fast recovery, so we did it with the tubes. She right after the surgery, when I saw her post-op, her ankle was moving again. She had full strength, and all her numbness was gone. She was extremely happy. She was just like, I don't know why everyone's so scared of spine surgery. This was the best decision ever. So the emergency surgery is always the most rewarding, because it's always someone that's extremely scared and they don't know what's going on, and when you treat them, and it's like, oh wow, this is not bad at all.
Well, doctor, I think you need a vacation. You haven't had a vacation in I don't know how many years. You're always working, but it seems like you love it and you're great at what you do. So I want to thank you for being here, Dr. Abdul Arain at One Oak Medical Center. He is an authority in the industry. If somebody needs to find you, how can they find you?
You can just find me on ZocDoc. You can Google me and just reach out to One Oak Medical. I'm always available 7 days a week.
Thank you. Appreciate you being here.
Thank you.